Hello, my name is Grace Elsie. I am a PGY1 pharmacy resident at Wake Forest Baptist Health, and I'm excited to discuss my research on olanzapine for the prevention of chemotherapy-induced nausea and vomiting in adult autologous stem cell transplant patients. My advisors nor I have anything to disclose. Wake Forest Baptist Health is an academic medical center in Winston-Salem, North Carolina. We have a designated comprehensive cancer center and perform over 120 stem cell transplants annually. The focus of this study is chemotherapy-induced nausea and vomiting. CINV is a clinically significant side effect for patients undergoing treatment with highly emetogenic chemotherapy agents. Previously, the standard of care was triple therapy using a neurokinin antagonist, a serotonin receptor antagonist, and dexamethasone. Now, clinical guidelines, including the American Society of Clinical Oncology and the National Cancer Comprehensive Network, support the use of olanzapine for CINV prevention in patients undergoing these regimens. However, its clinical use in stem cell transplants is not well defined. The two primary autologous stem cell transplant conditioning regimens consist of highly emetogenic agents, BEAM, consisting of carmustine, etoposide, cytarabine, and melphalan, is a multi-day regimen, versus using melphalan alone, which is a single-day regimen. Previously, there has been one study looking at the use of olanzapine for CINV in stem cell transplant patients using highly emetogenic conditioning regimens. The primary objective of the FONDO trial was to compare complete response during the overall assessment period. The study found a significant decrease in emesis and nausea for patients that received triple therapy plus olanzapine versus triple therapy alone. Therefore, the purpose of our study is to expand on the previous literature to evaluate the utility of olanzapine as an antiemetic therapy for patients undergoing an autologous stem cell transplant. The primary outcome of our study was a complete response during the acute period. The secondary outcomes looked at response during the delayed and overall assessment period. Additionally, our study analyzed safety and tolerability outcomes in patients using olanzapine. We evaluated this through collecting patients' QTCs at various points throughout treatment and by noting any adverse events that could potentially lead to the discontinuation of olanzapine. Our study defines several timeframes. First, the acute period are the days the patient received conditioning chemotherapy. The delayed period begins the first day after the cessation of chemotherapy conditioning and for 4 days after. Complete response is defined as no escalation of initial regimen, no breakthrough antiemetic use, and no emesis. The two possible antiemetic regimens are listed, with the difference being the addition of olanzapine. We performed a single-center, retrospective, non-randomized observational study. We selected patients from our stem cell transplant registry that underwent transplant from January 1, 2017 through September 15, 2019. Patients were separated into two cohorts based on their prophylactic regimen. Patients included were 18 to 69 years old, had a confirmed diagnosis of lymphoma or multiple myeloma, underwent an outpatient autologous stem cell transplant, and received antiemetic therapy with one of the two prophylactic regimens. For our exclusion criteria, I would like to note that we excluded patients that received conditioning chemotherapy in the inpatient setting. Statistical tests were performed. Nominal data was analyzed using chi-square or Fisher's exact. Ordinal or continuous data was analyzed using Mann-Whitney U and Student's t-test. A significant p-value was defined as less than 0.05, and an intention to treat analysis was performed. After review of the stem cell transplant registry records, 151 patients were screened. 23 were excluded for having an inpatient transplant, and another 7 were excluded due to incomplete documentation in the EMR. Therefore, 121 patients were included in the analysis. The baseline characteristics of the study population shown here were shown to be similar between the cohorts. Upon review of these characteristics, there were slightly more females than males, with ages around 60 years old, and most being Caucasian diagnosed with multiple myeloma. Please note that all multiple myeloma patients received melphalan, and all lymphoma patients received BEAM. Here are the results for our primary outcome. As shown here, the primary outcome is no emesis or use of additional antiemetics during the days the patient received chemotherapy. 22 patients in the triple therapy group achieved complete response. 77 patients in the triple therapy plus olanzapine group achieved complete response. This was statistically significant with a p-value of 0.002. Additionally, a subgroup analysis was performed, and both melphalan and beam conditioning regimens displayed significance in regards to the primary outcome. Also, as shown here, we did not find significance in the delayed and overall periods. We assessed the safety and tolerability of olanzapine using two measures. First, we assessed olanzapine in relation to QTc prolongation. All patients had resolution of a QTc less than 500 at completion of the conditioning regimen. Additionally, we had 5 patients experience adverse events related to use of olanzapine, including tremor, somnolence, and twitch. 3 of these patients did need to discontinue olanzapine therapy. There were a few limitations to the study. First, the duration of the prophylactic regimen varied between patients, as the conditioning regimen using melphalan is a 24-hour regimen versus beam being a multi-day regimen. This difference leads to variations in regards to total prophylactic doses of antiemetics used. Second, as patients underwent an outpatient transplant, the patient determines if and when they feel nauseated and need to take additional antiemetic medications, which could lead to selection bias. Thirdly, there is a potential underestimation of response, as we did perform an intention to treat analysis and some patients did need to discontinue olanzapine. Unlike the previous study discussed earlier, our study demonstrated that the addition of olanzapine to a standard triple regimen significantly improves patient outcomes during the acute phase. Overall, in patients that received olanzapine, overall emesis and breakthrough medications were decreased. Additionally, in regards to safety, olanzapine demonstrated a tolerable side effect profile with minimal patients experiencing adverse events. For our next steps, we plan to combine our data with other institutions. I would like to thank my study team for their support of this project. Here's my presentation objective and the self-assessment question. Thank you all for listening. Please reach out with any questions or feedback you would like to share.